I'm here to talk about drug-induced sleep endoscopy. I'm going to mainly talk about why, how, and when to do drug-induced sleep endoscopy. You've probably heard of this concept before, but the idea of sleep endoscopy is to identify the key areas that are collapsing or obstructing during sleep. We do this in the way we know how, which is to use our flexible laryngoscope. But the goal of it is to understand the phenotype of how people collapse and hopefully direct surgery. The field has moved toward discussion of site of obstruction as a very important evaluation for sleep apnea because a lot of people have multiple sites, and if you're not treating the certain sites, you probably aren't effectively managing the sleep apnea. So, what and how? Preoperatively, I have an instruction list. If you need to see what I send out to the anesthesia team, feel free to email me and I'll send you my very simplified instructions. But the idea is no sedation in pre-op. Ideally, they get a dose of glycopyrrolate to dry up some of the secretions and make your exam a little better, if possible, 30 minutes prior. Intraoperatively, it's the standard topicalization of the nasal cavity. Too much topicalization probably interferes. There's some evidence it might interfere with the exam, so we don't try to get anything into the throat, but I do topicalize the nose. And the instructions for anesthesia is it's a simple propofol infusion. I don't do a bolus. I say the minute the patient gets in the room and on the table, or in PACU or in pre-op, if you're willing to do that at the surgery center, you just start the propofol infusion at 75 mg per kg per minute, and I always start at that dose and let it run for a while. So after about 5 to 7 minutes at that dose, if the patients are still chatting with you, I allow them to go up, but in communication with me, and basically step up slowly to titrate to just that loss of consciousness where they're not responding to voice. Some tips. So the goal of the sleep endoscopy, which I'll show in a minute, is to evaluate location, direction, and severity of obstruction. The tips I have are to be clear to anesthesia before. I think they're used to seeing the patient move when we have an endoscope in, and they really try to bolus the patient extra so it doesn't upset the surgeon. So in this case, it's a slightly different goal. Expecting obstruction. These patients are obstructing nightly, and if desaturation makes them uncomfortable, a simple jaw thrust is all that's necessary. I've never needed to intubate a patient, never had to trach a patient. I very rarely need to have the mask placed on the patient if done in this manner. Have a lot of patience, because you really want that minimal amount of sedation to capture as they're going to sleep. If you do too much sedation, patients will obstruct completely. So you want to place the scope while they're awake and watch for obstruction to start. The scoring classification is the VOTE, written by Eric Kazarian and a couple others. You're looking at the velum, oral pharynx, tongue base, and epiglottis, and you're grading partial versus complete collapse. Complete is defined as anything greater than about 75% collapse in a variety of directions. So we'll see a couple examples here. So for palate obstruction, this is a couple videos here showing you posterior wall of the velopharynx, anterior wall, you see that uvula hanging down the tongue. This is AP, palate collapse. I have a couple tied here. This one is more circumferential palate collapse at the base of the uvula, is what we're delineating as the velopharynx. And this is important because when we talk about Inspire candidates, those with circumferential collapse are considered not candidates. They should probably have some form of palate surgery first, such as an expansion palatal pharyngoplasty. This patient has huge tonsils. That's an easy one to manage and focus on, but just to show you what that looks like on sleep endoscopy, you see the uvula flip up there. And so this is velum and oral pharynx collapse. So for the lateral oral pharyngeal wall, there are a certain subset of patients that have a very lateral side-to-side collapse in the oropharynx. This is important to look for because this is associated with higher BMI, higher AHIs, and this is very hard to treat surgically. Most of our surgeries are designed to pull that palate forward, but the side-to-side action is harder to manage. Evidence on whether our expansion or advanced UPPP techniques fix this is still under study. This is another example of lateral side-to-side collapse. Let's see, I wanted to show you tongue base really quick too. So this is assessing mainly looking at that tongue base. You can see quite a bit of a collapse as that tongue falls back, along with lateral oral pharyngeal collapse. And I want to show you independent epiglottis collapse. So there are certain subset of patients in which that epiglottis acts like a lid when they're asleep. The negative pressure when they're breathing really sucks that epiglottis down, and that is a different kind of pathology or phenotype of the airway. So what do they mean? Complete concentric collapse happens in about 15% of patients. These are not candidates for Inspire, associated with higher HI and BMI, like I talked about. Lateral oral pharyngeal collapse can be harder to treat surgically. Epiglottis collapse is one of those findings you can really only see on a sleep endoscopy and hard to predict for in your awake exam. When to use it? This was done to look at surgical non-responders, people with recalcitrant OSA after surgery. Does sleep endoscopy map to surgical success? This is controversial. There's studies showing that if you treat all sites of obstruction, it doesn't guarantee success. This is probably because we don't have the perfect surgery to treat all kinds of obstruction yet, or thinking of that has to evolve. And then what we don't know is how does changing one site of obstruction change the rest of the airway, because it's a dynamic system. So in the end, it's easy to do. You characterize the airway. The myths are you cannot diagnose sleep apnea with a very quick evaluation of the airway in this manner. It's not natural sleep, but it is a view of what could happen during sleep in certain patients. How to integrate it into the surgical plan needs to be evaluated. When to do it, for me, I do it before a specific surgery for surgical planning or for evaluation of Inspire candidacy, and for patients that have had prior surgery and we're trying to look for next steps.